Welcome to Make America Healthy Again. Join Dr. Charles Antinori and friends as they share solutions, tips, and insights that only doctors know for creating better health. Here's Dr. Antinori.
So this is the Make America Healthy Again podcast. I'm Dr. Antinori, and I have yet another Antinori, my nephew, Anthony Antinori. He's a computer expert and been doing it for, 25 years, right?
Roughly 25 years, yeah.
From when it was like really when computers started. You were like right in the very beginning.
Windows 3.1, yeah.
What was it?
Windows 3.1 back then was just...
Right, yeah. Is that the system? That's the first one. Yeah. What was it, Bayonne Hospital, the first place? I
first started, down in Bayonne. That's right.
Wow, yeah. Wow. So anyone want to give a little of your background for the listeners?
Sure. So I am a healthcare IT executive working in a major New York metro area hospital, supporting both digital solutions and electronic health records.
Right. And you said you were starting to work on AI a little bit too, huh?
And AI is now sort of integrated into almost everything we're doing here, right? From revenue cycle to electronic medical records to our help desk and call systems.
Wow. Amazing. And we want to start talking a little bit about the electronic health records. We were just talking about the Cerner and EPIC. They got started under the Bushes, in a very minimal way, but it's just kind of been like a snowball going downhill.
Yeah, and early 2000s, first getting started, we had the smaller vendors, Meditech, Cerner, EPIC was just sort of starting out. And then the introduction of the federal government's healthcare HITECH Act, I think in conjunction with the Obamacare.
Right, the Affordable Care Act.
Yeah, right. All of that really sparked the growth of EMRs in general, but more so in the private practice space. So the physicians' offices were now sort of mandated in a way to go out and make themselves electronic. And that was at the time very nebulous also. Like nobody really knew what that meant, right? It was just go get an EMR, and some of them were just getting an EMR to get an EMR. They weren't really even doing anything with it at the time. They were just saying they had it and still had a paper chart.
Then you had to do meaningful use was the phrase,
and
right? You could get
$40,000
a year, which sounded like a huge number at the time. But you had to prove that you were doing meaningful use. Yeah.
For that exact reason, right? The doctors were just getting it, and then they had to prove to the federal government to keep their Medicare, Medicaid money, were they actually using it, and in what way were they using it, and for what purposes. And I think a lot of that then sort of created its own problems, right? There's all of these little onesie twosies EMRs out there, and that caused its own set of issues. But over the last, I'd say 15 years or so, the world has sort of consolidated to a couple major players in the space, Cerner, EPIC being sort of the de facto standard nowadays for most of the large institutions across the board. But then there are the regional players and the smaller EMR vendors for the mom and pop physician services that are, still sort of not part of a large institution yet at this point, that like many are. But that has sort of been the trajectory for most practices going on to EPIC, along with a large anchor system in one way or another, depending on what their deals are.
My particular journey, it started in 1998 with a thing called TDS, which was, I don't know if you ever heard of that one. It was that Cooper bought it mostly for computerized order entry. And it's funny, it pushed several of my partners refused to go to Cooper. Once they, that was like part of our exit out of Cooper, was that some of my partners didn't want to go there if they had to do computerized. And it was also where I learned my first things about computer, really. I didn't even know what the little X in the corner of the box meant at that time. I had a female tech at Cooper had to instruct me how to like turn the computer on and things like that, And then I've been through that with them was Meditech.
Meditech is another
Sorian, and Cerner, and then as we were talking about the system, the hospital I'm at now is going to go to EPIC in 2026. and which seems to be the trend around the country. I mean, Epic is the largest system, and it seems to be getting, to me, even larger. Although if you say if Cerner was bought by Oracle, that might. They might.
Yeah, they're also international now. So Epic has a lot of clients that are in other countries. So it's growing in terms of users, and they have a huge campus in Wisconsin. It's multiple buildings, a huge amphitheater. They hold client events. It's really a big thing to do in terms of the community of users and the way that they run the platform and all the things that they do. So I think it's a great system. It's really worked well, at least in my career.
Yeah, well, that book I was talking to you about, the Digital Doctor by this guy Wachter, said the same thing. He had a whole chapter on Epic, and basically, and interesting. He was a computer kind of guy, a physician, but it's almost like a specialty almost. There's usually a physician that's kind of on the interface between the computer guys and the doctors, and I think he was one of those guys.
We have many of them, many of them
Right.
as well that are both practicing physicians as well as informaticists that sort of help shape the way that we deploy the tools, both practically and for the technology, because it's no good if something is built and designed, but the doctor can't use it, or it's just hindering care or something like that. So it really helps to have a practicing physician kind of make note of why or which ways we should be building these things to work in general, right? The IT guys shouldn't be saying, just do it that way, because they really don't know the business of seeing patients.
Right. He was working at the University of San Francisco, not Moffitt, but I think it's just University of San Francisco Hospital. And they designed their own system first around 2000 or so, early 2000s, and used it for like 7 or 8 years. And then they went to Epic. And actually, there's kind of an interesting story. I would say a fourth of the book goes to this one episode where this one kid got 36 doses of Ceftra or something like that, because the intern that wrote the order, apparently you can on one page you order like per kilogram, or you can order a dose per kilogram. I mean, a dose of Ceftra per day for a kid, or you can order a dose of a Ceftra per kilogram for this kid. And she clicked on the wrong one and ordered it per kilogram. And it goes through the whole sequence, like the pharmacist was really busy. It went through a satellite pharmacy, and he didn't see it.
Didn't get
they had a
caught, right?
computerized dispensing system, which I've been to several hospitals that have that already. So the computer just, the robot just spit out 36 doses.
That's what you tell it, right? That's what you tell it to do, right?
Just did 36 doses of Ceftra. The nurse that was working on the floor was like an ICU nurse, but she was rotating to the pediatric floor, covering this kid. So they were busy, and she didn't want to bother her supervising nurse to ask her about how come this kid was getting so many doses of Ceftra. And then the kid apparently had some kind of a congenital condition where he gets colonoscoped or something. And before he left, the mother told him, "Well, I'm going to prep you for colonoscopy, and you may have to take a lot of pills or something like that." So he took all the pills. He apparently had a seizure, but didn't have any long-term ill effects from it. But again, right. the point in the book was how you just can't make anything foolproof, because the fools are so ingenious. That's why. The other thing about from a doctor's point of view about the computerized health system is the combination of the two things: the Affordable Care Act, which, speaking for myself and an awful lot of physicians, everybody sort of handwriting on the wall, this was just going to be basically a large expansion of Medicaid, which is almost unsustainable. I don't know how it is with the hospital. They must pay the hospitals, Medicaid must pay the hospitals a more realistic reimbursement than they do for doctors, because a doctor really, you could be the busiest guy in the world, and if you had all Medicaid patients, I don't think you could, pay your bills.
Yeah, you have to see as many as you can, right? Right.
Right. Yeah. And so that was that sort of got doctors, going to work for hospitals basically. And that's, if you look at the percentages, I mean, before the Affordable Care Act and the HITECH Act, maybe, I don't know, 20% of doctors were employed by hospitals, something like that. Now I think it's up to like 70 or 80%, and that's those two things. The other, like I said, the other part was, the one was the Affordable Care Act, the expansion of Medicaid. And then the other one was the HITECH Act, forcing people to buy computers and maintain computers, which, and again, in the beginning, they said $40,000 a year. It sounded like a huge amount of money. I don't think that's enough.
That's a drop in the bucket in today's standards. I mean,
even for a small doctor office to run a computer and keep it updated and, have enough other things to go on.
The biggest thing for the physician's office is not so much anymore on the EMR. I mean, that's a huge expense. It's huge, but it's keeping up with cybersecurity, cyber threats, hacking.
Yeah.
It's an ever evolving platform. You're always one step behind the hacker, and you're held to such a high standard with HIPAA and governmental regulations to keep the privacy and security of all of these records, right? And so you have to be so vigilant on keeping things secure and up to date. It's a huge work effort and expense for a practice to make sure that they have all of this stuff up to the most recent standards, and cyber insurance, right? Something that you wouldn't have had, maybe 10 or 15 years ago, on top of whatever malpractice and everything else is. The landscape has changed so dramatically in terms of information technology that you have to evolve with it, or you just get left behind.
Yeah.
So I think a lot of the groups end up joining the larger systems because they end up just taking care of all of that, right? And so you just practice medicine.
Right. Well, that's really, that was a big point. The other, again, from a doctor's point of view, one of the hospital I was at until 2011 probably had, I think I knew everybody in the IT department. There was like 3 or 4 people in the IT department, and only a couple of them were like really trained IT people. The others were kind of like young kids that ran around and did stuff, but now when I went to the hospital I'm at now, when I got there, they switched over to, if they were on Cerner, they were on Saurian at that time. And it was like it was the largest department in the hospital. Is it where you are? Is it one of the larger departments?
You'll probably get that same sentiment from most New York metro area hospitals, large medical centers. The IT departments are growing in scales of hundreds of people, right? So they tend to be complex and supporting every department in the institution, because radiology is different from surgery is different from lab.
The lab,
right, all of these different areas have a very specific lens in which you have to support them, because the instruments are different, or the technology is different, or the physicians are different, right? They're doing different things, and so you can't have one young kid anymore just running around with a keyboard and a mouse. It's very sophisticated, and they have to be trained and upskilled to support the things that the clinicians are doing from a technology perspective.
Yeah. We mentioned the lab. That's how that was for years. That was like your only link to the computer. When I was a resident, we had to get the lab results. It was a big thing. You had to make rounds. You had to call, and it drove everybody nuts. The people in the lab hated it because they were calling, giving out individual lab results. A million phone calls to get a million lab results. And then the computers came in, and it was better for probably 10 or 20 years. That was probably the only function of the computer, was to feed the lab results, and then the only function I saw, I'm sure, from an administrative point of view, was the other. It's funny, one of my book, To Make America Health Again, I talk about why medical care has got expensive. This is one of the things. And you talk about how big the departments of IT have become. I remember back in like early 1990s, 92 is when the government sort of woke up and realized that we're spending we're spending almost 20% of the GDP on healthcare, and they tried to start doing something about it, And at that time, I remember reading, pretty sure it was the Philadelphia Inquirer, and they had looked to see they compared 1970 to 1990, and the number of doctors more or less the same, number of nurses was more or less the same. the number of hospital administrators had increased like exponentially. It had gone from like, maybe like 100-fold, and I was at Columbia Presbyterian for resident. It was the largest voluntary hospital in the country, 2,500 beds at that time. And I only knew one administrator, was this lady, and she was a nurse. She walked around in a nurse's outfit with the nurse's hat on. I'm sure there were others. She couldn't have done it by herself. Right. Lillian Brown was the only hospital administrator that we all knew, and it's just virgin like that. Yeah.
Yeah, it's a very different time now. Yeah.
Yeah. Dude, I'm listening to a book now too. Comparing the 10 healthcare systems, and they talked about the United States, and they were saying that they even this book brought up the thing, and Wachter talks about it too in that digital doctor book, of the interfacing them. That's been one of the problems, that this between the hospitals and between doctors' offices. Like in our hospital now, a lot of the offices are on the same system as the hospital, which is a very good thing,
Yep.
But still, if they come from, even like Atlantic City to Vineland is not very far. Yep. But sort of people might have been under Atlanticare, and it's really not easy to get the results with that. Anything doing on that? Is there any?
Yeah, so I think that's one of the big value adds and strengths that Epic has bring to the table, and that's, I think, one of the reasons why many institutions are going on it is it allows you as an external entity that's also on the common platform of Epic to pull records through one of their what they call Care Everywhere, Care Elsewhere. I forget what it's branded nowadays. Care Everywhere platform allows you, if you're in Epic at any one of the other Epic institutions, you have the ability as a clinician to pull their records. Obviously, there's consent forms and all that other approval stuff and release, but it's all done electronically, so it's fairly easy to get your information. And then we have these other regional institutions called RIOs, Regional Health Information Exchanges, that dissimilar platforms that are maybe on Cerner or others can contribute information to, that are run by the state and federal governments, that are slowly dwindling down as people go on Epic, because there's the use for them and the need for them becomes less and less, and they become more of a reporting agency and a value add for other ways funded by the government. But the RIOs were big during the HITECH Act because of all of the reason of the EMRs popping up in different flavors and approaches, and the RIOs were the answer to that. But now that Epic and Cerner and others are being more interoperable, where you can get records from each other very seamlessly, that's becoming more and more of a need. But the interchange when you're on a common platform makes it very easy to get records. It just becomes more of a matching algorithm to make sure that the person that you say you are pulling it from is in fact the same person in another institution, and that you're pulling the same information. So there's a lot to do around record matching, consent, and authorization access.
Yeah, we had a thing called New Jersey Shine that did that. That was probably the New Jersey regional.
Yep, one of them. There's a couple in New Jersey. Yeah.
You want to talk a little bit about? We got maybe another 10 minutes or so. You want to talk a little bit about what's going on with AI at your institution?
Yeah. So I think AI across the board has really opened the pathway to many different new and interesting use cases, both in research, also in the clinical setting, and just daily operations in general for the system. But more specifically about the patient care aspects, there is a platform that's being used today, and also many other. We're using one called Bridge, but there's many others that do a very similar thing, which is sort of ambient listening, being able to have an app on your smartphone that's interconnected to your EMR that will listen to the conversation that you're having with the patient during the interaction, and then behind the scenes taking that conversation, summarizing it, putting it into the right places in the template within the EMR, and then dropping that summary into the system for you as the clinician to then sign off on or approve, if you will, so that all of that information, the documentation, is done for you, basically, and all you have to do is review it and approve it in the system. Whereas before, you were sitting there, your hands were on the keyboard, potentially kind of looking at the patient, you're typing away, clicking buttons and doing all that kind of stuff. This is a very new approach to the interaction between you and the patient, and then having the AI make the determination to put the relevant bits of that conversation into the EMR. So even if your conversation veers off to say, oh, did you see the Yankees game yesterday? How was that at so-and-so? It's not going to capture that. It's not going to put it in the chart. It's
that right. It'll sort that out, huh? Yeah.
It's intelligent enough to understand when the nature of the conversation becomes clinically relevant, to drop it into the right place into the system. Wow. So it does take a different approach into how the documentation gets done, and people are adopting it. So it's new, obviously, and it'll keep getting better with time as AI improves and the way that we use things improve. But that's just one use case of how things are being done here in this.
I told you my experience has been just with this podcast. Since we're doing it on Zoom, they put this AI companion, and it listens to the whole thing, and it'll send me a very nice summary of our conversation. And then it helped me out because the people who edit this asked me to do a description. And in the beginning, I was doing a description on my own. It'd take me 5 or 10 minutes, but now this thing comes out, and I'm amazed, pleasantly surprised at how accurate it is, and how it really served the purpose.
Yeah, absolutely.
Really good thing. The other thing, just to finish up, we talked a little bit yesterday, and I did some reading. Picked up the New England Journal, the most recent edition, and it has educational strategies for the clinical supervision of artificial intelligence use. A big long article talking about. This is not so much what you were talking about, not just listening. It's more how to work it into teaching and learning. They're concerned about the learning. I'm concerned about the learning too, because I know, even on a simple level, the GPS in your car. When I do my GPS, I don't learn where I'm going at all. I just follow the GPS.
Right.
And the concern is if you start just Googling everything and AIing everything, people aren't going to really. Your brain is going to sort of atrophy.
Well, so the argument too is can the AI read a X-ray or a radiology image better, worse, the same than a physician can? We may find out. I don't know. Yeah. I think we're learning that, right?
I think it's probably a good check. You know what I mean? Like the AI might pick something up that the physician doesn't. Obviously, at this stage of the game, you want a physician involved.
Right.
but I think that it's possible that it may. With the guy I had a talk, Doug DePice's cousin Sandy, he's a physician. He's very much involved in developing AI for physicians. He was saying, like, even with the robotic surgery, there are programs in the robots now that AI programs that help guide you when you're using the robot for surgery. Tell you, watch out for this thing over here. Stuff like that.
Yeah. And they're using robots in the ORs here as well. I mean, it's an interesting time to be in the medical field. I'll say that.
It really is. Yeah, it really is. Well, Anthony, I think we're getting close to the end here. It's been great talking to you. I'm really enjoying these podcasts. I get to find out all sorts of interesting things about people in my family, and friends.
Yeah, for sure.
Yeah. Well, thanks a lot.
Do more of them. I'm game. So let me know.
Game? Okay, we'll see. I got another 13 or so to do. So
all right.
I might take you up on that.
All right.
See ya.
See ya.
Bye-bye.